Time for part 3 of chapter 21, toxicology. So we're still looking at some of the specific drugs and some of the signs and symptoms we would expect to see from these specific drugs. Another one is hydrogen sulfide. It is normally an inhalation that occurs. It's a highly toxic, colorless, and flammable gas that has that rotten egg odor. Most of the time it's used to commit suicide. And obviously, if you smell that, if you are concerned that this is what it is, then you need to leave the scene, exit quickly, and get hazmat on the scene. Signs and symptoms of inhalation of hydrogen sulfide: nausea and vomiting, confusion, dyspnea, loss of consciousness, seizures, shock, coma, and when not treated, cardiac arrest. This is a depressant of the central nervous system. Most of the impacts are going to be on the lungs and the cardiovascular system. When your patient has been decontaminated, because they need to be stripped and flushed, your job is going to be mostly to monitor the respiratory and cardiovascular systems, support any issues that they have, and transport to the hospital. Next, we'll look at the sympathomimetics. So these are stimulants that are going to mimic the effects of the sympathetic nervous system. So they mimic the sympathetic nervous system. We're looking at a good number that are all known mostly by their street names. So ecstasy, ice, meth, speed, Molly, angel dust, coke. All of these are increasing and stimulating the central nervous system. So they're all going to show impacts to the heart and respiratory system and a increase. And they're really kicking in that fight or flight symptom. Stimulant causes an excited state. So we are going to expect to see hypertension, tachycardia, dilated pupils, and an increased respiratory rate, tachypnea. It includes your methamphetamines, your amphetamines, your benzodrines, MDMA. They're often injected or ingested to get the high. Cocaine is a sympathomimetic, which can be taken in a lot of different ways. One of the problems that we have is the fact that it can often be mixed with other drugs. Smoked crack is the most potent, and normally it will either be snorted or injected. When you reach somebody who is smoking crack, they have a significant tolerance and they're looking for that euphoria quicker. And all of that actually only lasts less than an hour from one dose of cocaine. An acute overdose is a true emergency. Overdoses on sympathomimetics are going to increase the risk of stroke. It's going to be a patient who may experience hallucinations and paranoia. Your goal is obviously not to leave this patient unattended unless your safety is a concern, and provide prompt transport. The bath salts, we're seeing an increase in the issues with these. So these are synthetic cathinones. Bath salts, they can be sold as bath salts legally, but in reality, what's happening with the use of these is that feeling of euphoria, the belief of a mental clarity, an increased sexual arousal. But if you Google abused bath salts, you'll actually come across stories of people who start to have hallucinations, who are paranoid, who have actually eaten other people. Don't ask me, I have never tried it, but those stories definitely make me not want to. You get teeth grinding, muscle twitching, headaches, elevated heart rates. Our goal here, obviously, first is our own safety, but to keep the patient calm. These patients may need to be sedated, and obviously, as a BLS provider, we can't. And law enforcement will probably be involved. Marijuana, you know, and a lot has changed in time over marijuana, about like legal use, illegal use, etc. We have to understand that, you know, regardless of whether it's legal or illegal, any type of drug, if we are running the patient because they have called 911 due to a reaction, we need to treat that patient regardless of how we feel about the drug. Marijuana is a drug that will produce a feeling of relaxation and euphoria. It can impair short-term memory and slows the ability to do complex thinking, complex problems. Very high doses can lead to hallucinations or paranoia. So if we're coming across those patients who have taken too much, been exposed to too much THC, then we need to just keep them calm and transport them. Unfortunately, we're seeing a lot of marijuana that can be laced with other drugs, so we may see the side effects of the other drug as well, and the patient may not always know that. You know, you may see marijuana in the form of edibles now, as it has been legalized and put into different forms. And that obviously is a concern as well of kids who are ingesting it. We've seen a lot of stories, and here recently saw a couple of stories about kids who ingested THC-laced candy and the impacts that that's going to have, being that they're smaller, they weigh less, and they have a lower tolerance. So synthetic marijuana, which also goes by the name of spice, is another problem that we're going to run into because this is a highly unregulated. Not that marijuana necessarily is regulated, but because it is a blend of herbal incense and marijuana used to produce the similar high, there's also the risk that this will be uncontrolled in terms of too much and can lead to a complete loss of consciousness. Hallucinogens is yet another type of drug that we may run into. I think your classic example that we're used to hearing about is LSD. And then there's a bunch of others, PCP, hashish, Jimson weed. I've had a 14-year-old who did that. He was the one, I believe I've told you, who got a Foley catheter without any pain meds or being knocked out. Marijuana is also treated as a hallucinogen. Peyote, you know, the hallucinogens alter the sensory perceptions. So they're going to cause visual hallucinations. They're going to increase the patient's vision and hearing, and kind of separate that person from reality. And this is going to be somebody who experiences the, quote, bad trip, but they're also going to have hypertension, tachycardia, anxiety, paranoia, and those hallucinations. And the goal is not to play into those hallucinations, but to keep the patient calm and treat the signs and symptoms. We always want to use a calm and professional manner. We've got to put our own safety first. Unless your patient is a danger to themselves or others, restraint shouldn't necessarily be needed, but we need to treat airway, breathing, and circulation, and talk to our patient, not leaving them unattended. Those anticholinergic agents that we've talked about, they block the parasympathetic nervous system. And so this is a phrase that we see a lot of people utilize in the medical field to help you kind of remember the reaction to anticholinergics. And that is hot as a hair, blind as a bat, dry as a bone, red as a beet, and mad as a hatter. So, you know, skin is going to be red and warm to the touch. Visual disturbances, dehydration, and altered mental status are all going to be common in these patients. Drugs, when used inappropriately, that can cause those reactions: atropine, Benadryl, Jimson weed, and amitriptyline. Obviously, Benadryl is probably the easiest one. It is over the counter, and and easier to get. You may actually see some antidepressants, some tricyclic antidepressants that cause same impacts as anticholinergics. Death is going to be rapid. When at high enough doses, this patient can go from normal to death within 30 minutes. Seizures and dysrhythmias are going to be treated at the hospital. Nothing we have is going to counteract the anticholinergics. And then you've got the cholinergics. So these are going to overstimulate normal body functions. And these are really the nerve gases that we normally see in insecticides and in chemical warfare. So again, it might be that somebody, used an insecticide too close to a population, but for the most part, what we end up seeing when we see a large number of patients is that this was a criminal release. This is where we get sludgem, so salivation, mucus secretion, runny nose, urination, diarrhea, tearing of the eyes, and a heart rate issue. All signs and symptoms of exposure to a cholinergic agent. Look at dumbbells as well, so not just sludgem, but dumbbells, diarrhea, urination, meiosis, bradycardia, bronchospasms, and bronchorrhea, emesis, so vomiting, lacrimation, the watering of the eyes, seizures, salivation, and sweating. Dumbbells is a good way, and if you see a large number of people who are exhibiting these signs and symptoms in a small area, you definitely need to be concerned about the criminal activity associated with this release. Sludgem, as I said, salivation, lacrimation, urination, defecation, drooling or diarrhea, gastric upset, emesis, and muscle twitching or meiosis. So dumbbells and sludgem are good acronyms to use to remember the signs and symptoms of exposure to cholinergic agents and organophosphates. Decontamination's got to take priority because we cannot put this patient into an enclosed ambulance for transport. After decontamination, we are likely to see a decrease in the secretions. We need to consider whether we need to suction our patient to ensure their airway isn't compromised as a result of the increase in secretions, and provide continued airway support. We have antidote kits. There are drugs that we can give when our patient has been exposed to cholinergic agents, and it is an atropine and pralidoxime autoinjector. So it's a kit that in reality we often don't carry with us and will take some assistance in getting. You might have some miscellaneous drugs, some other things that people can overdose or abuse, including different solvents, different over-the-counter meds, antidepressants, or that it just is an oops, I took it and shouldn't have, due to just not remembering that they've already taken it, or taking it, just because they want to harm themselves. You've got to consider that you may not understand all of the signs and symptoms, and so as a result may need to, again, call medical control. I once had a patient who overdosed on throat spray, so Chloraseptic, and I had no idea. I've only ever used it once or twice. Well, by calling medical control, or poison control, they were able to tell me what to expect and how to treat my patient. But they also are going to follow the patient, and they're going to find what hospital we're transporting them to and see how the patient is doing at the end of the call and when they've been discharged. Aspirin is a drug that we see people try to overdose on, mostly self-harm. Too much aspirin ingestion can cause nausea, vomiting, hyperventilation, and in the long run will actually harm the liver. Patients who have overdosed on aspirin may also show anxiety, increased respirations, high temperature, and they are at risk for a seizure. It may be unintentional, it may be intentional. It's really not our job to decide why they overdosed. It's our job to treat them. And then we also see patients who will OD on alcohol. Whether it's intentional or not, they have alcohol poisoning. And that can cause many number of signs and symptoms, including tachypnea, which is increased respirations, vision changes and blindness, renal failure, and death. Food poisoning, it's going to be mostly because they ate bad food. So food caused by bacteria, or they ate food that wasn't cooked correctly. So there's certain foods that when cut or cooked incorrectly will cause a patient to be poisoned. The most common food poisoning we'll run into is salmonella, but rotavirus and norovirus are some big ones, Shigella. All of the things listed in 21-7 are all potential causes of food poisoning. Salmonella is characterized by severe GI symptoms, and normally within 72 hours of ingestion of the food, including nausea, vomiting, and diarrhea. Our goal, of course, to prevent salmonella is appropriate cooking and cleaning techniques to ensure that there's no cross-contamination. But obviously, when you eat out, you can't necessarily guarantee that. More common are often the bacteria in leftovers or that are unrefrigerated. So that potato salad at the church picnic or the family reunion, or the eggs, hard-boiled eggs that were left out. Obviously not something that we want to have to deal with. And just like anything else, when the body takes in something it doesn't like, it's going to try to get rid of it. And so your signs and symptoms are going to be gastrointestinal in nature. The body's goal is to get rid of it the way it came or the other way out. You've got to be cautious when you have botulism as a potential. So patients who are experiencing neurological issues, so blurring of the vision, weakness, and difficulty speaking and breathing, these are significant and severe issues associated with the toxin ingestion. And obviously we can't get rid of the botulism, but we can get them to the hospital for treatment. It's not our job to find the specific cause. It is not my job to say, oh, I know what the problem is. It is my job to say, you know what? They're vomiting, they're nauseous, they think they ate something, let's get out of here so that we can treat them, get them the help they need to the hospital. Plant poisoning is another issue, ingesting an inappropriate plant, being down, going around outside, eating the wrong berries, thinking you picked the right thing and it wasn't. That's why I don't like to eat plants, because there are so many that can cause issues. It is impossible to memorize every plant. We don't expect you to look at a plant. That's not going to be a test question to identify plants. But we do need to recognize the signs and symptoms of the poisoning to help treat the patient. Here's just a couple of pictures of different plants that are actually poisonous that you might come across in nature. Some more. They all look cute, some of them. But if you were to accidentally ingest these, they would cause reactions. Additionally, you can touch or absorb the poison on the plant, poison ivy, poison oak, and they can cause an irritation of the skin. When this happens, we treat it. We treat any respiratory issues that may arise, any breathing issues, and we transport them to the hospital.